Hello, good morning, good evening, good afternoon. Welcome to our exam prep, IBLCE exam prep. You've got this webinar. My name is Angela Love-Zaranka.
And I am Sekeita Lewis-Johnson. Thank you and welcome. Good morning, good evening, and good afternoon.
So we are here today to help you to figure out how to pass the IBLCE exam. I know a lot of you have been studying for a while, and so we are here to sort of finalize these last few weeks before we start, before you're really getting ready for the exam. I know a lot of people are already feeling just a little bit anxious about it, and so we're here to help to try to allay some of your concerns. I am Angela. I have worked in the field for over 30 years. I've done community support, I've done hospital-based, private practice. I've served on boards of directors specifically for the International Board of Lactation Consultant Examiners in writing the exam, as well as the International Lactation Consultant Association. Sekeita?
Yes, so I started off as a CLC in 2005, and in 2008 sat for the same exam that you're preparing for. So I've been practicing for a little over 12 years, 10 years, 11, something like that. I just resat actually in 2018, so not too far gone from that. I've worked in the hospital setting, primarily community setting, home visits, private practice. So Angela and I really align in our experiences. They kind of, go hand in hand.
Yes, yes, yes. So welcome. This is going to be a bit of a long session. We are here to answer your questions. And so how do you ask questions? If you are on a desktop or a laptop, this is where you can find the questions box. If you are on a mobile device, it's right here near the bottom bar. And so this is where you're going to find how to ask a question. So just want to let you know, we also have Julie and Kim on the call today. They are both IBCLCs who've taken the exam within the past 2 years. And as a matter of fact, Julie sat it with last year when they used the live remote proctoring. They are part of our fabulous support team here at LER. And Steve is our technical magician. He is also on the call. So if you have any tech issues, also type those questions or comments into the questions box. A couple of ground rules here. Please don't photograph or record the information with the camera, phone, or any other equipment. We are recording it though, so not to worry, we are recording this and you will be able to review this session as many times as necessary. Questions will be answered during the session by Julie and Kim, as they're both IBCLCs. Sekeita and I will answer questions at the end, even if it means the session is going to go longer than the 90 minutes that we have allotted. Okay, let's dive in. Sekeita, you ready?
I'm ready. Let's go.
Okay, here we go. Medications.
Before we get into the exact slides regarding medication, I want you all to just take a deep breath. Take a deep breath in, let it out. This is designed for exam prep. So I'm not getting into the nitty gritty. I'm not going to, this is really just general information that will help you be able to answer the questions. And so I want you to just really, because the last time we did this, Angela, you remember there were so many questions about medications and people were getting hung up. And so before you start to ask those questions, just really key in and listen to some of the key points, because that's all I'm doing is going over key points, things to know. So next slide, let's get into it. So some of the key things about drugs. Remember, the amount of drugs that goes into the milk is excreted into the milk depends on many factors. One of those is the milk to plasma ratio, which is useful to evaluate the concentration of the medication in the plasma as compared to in the milk. So plasma meaning our blood components, milk is milk, okay? The relative infant dose is a very important clinical parameter to determine the safety, especially related to infants. So it's usually expressed as a percentage of the maternal dose. And according to HEL's medications in mother's milk, medications with a relative infant dose less than 10% is considered relatively safe for a full-term infant. So remember that, full-term infant, okay? So a relative infant dose that's greater than 10% for a full-term infant should be a cause for just a pause for further assessment of the situation. And then when we look at oral bioavailability, that refers to the ability of the drug to reach the circulation after it's ingested. So think about if there is medication in the milk, that means that the baby will ingest it, right? So drugs with low oral bioavailability are generally poorly absorbed in the infant's GI gut, in that tract, and they are destroyed by the gut, or they're either taken up by the liver prior to even entering into the infant's circulatory system. All right. Keep in mind that medications enter the milk compartment only from the lactating person's blood. So the medication would have had to enter maternal blood circulation in order to reach the milk. Okay. Also remember, and this is key, that during the colostrum phase, medications transfer into the milk easily. However, the dose transfer to the infant is lower due to the limited milk volumes, and there's a reason for that. The reason being is that when during the colostrum phase, the alveoli tissues, they're not as expanded, but once they start to expand, there's little room for the milk to kind of trickle down if you think about it. So think about having all these balloons that are just deflated. The more deflated, the more stuff can get in it. When you inflate them, they all kind of clump together and they keep things from dispersing. All right. So that's a good way to think about it. Next slide, please. Angela, you like that balloon analogy, don't you? Analogy. All right, so most drugs that enter, we're talking about key points. Remember that. Drugs that enter are usually at clinically insignificant levels, all right? In order to determine the safety level, you're gonna look at those key things I just talked about, the relative infant dose and the lactation risk category. By now, if you are sitting for the exam, I would hope that you know that L1, when we talk about lactation safety or lactation risk category, we usually talk about it from the standpoint of how HELL outlines it, which is from L1, which is the safest, to L5, which is hazardous. And then there's everything in between, okay? So be cautious also of high vitamin doses and unnecessary medications. I believe HEL's new book in 2021 mentions something about herbals. So keeping in mind that yes, generally herbals are natural, but natural doesn't equate to safe. So you want to keep those things in mind. Avoid high doses of medications that have sedative value or sedative effect, such as opioids. There's other medications to avoid when lactating, which would be radioactive agents, chemotherapy drugs, which is another word to say anti-cancer drugs, and high doses, excuse me, high doses of iodine. Next slide, please. Okay, so key points. Remember, drugs may transfer into the milk if they have high concentrations in the lactating parent's plasma, those that have low molecular weights that are less than 800 Daltons, medications with low protein binding, and those that pass easily into the brain. So it's always safe to check your resources and choose medications with short half-lives, high protein binding, low oral availability, and or high molecular weights. Next slide, please. So antibiotics and pain medicines, there are the most commonly prescribed to breastfeeding and chest feeding mothers. And so you will get many questions. Really, I'm not sure on the exam, but in your practice, you will have lots of questions about antibiotics. And you may have a couple on the exam. So as a rule, antibiotics are safe to take. Cipro, which is ciprofloxacin, is one that note that that's an L3, and that can be associated with GI problems for the infant. So you want to choose another antibiotic. Also, eye preparations, anything for the eye, it's okay, it's safe. Drops are safe for the eyes. If you're not familiar with many of the drug names, it's helpful to know that most antibiotics end in CIN, as in ampicillin, okay? And that's true for many, but not all. So when you look at this list, you want to look at, all the pretty much is IN, and then you have, well, I think they're all INs, so that's good. And so look at this list and you look at the category. Some people got hung up really on, do we need to know the generic name or do we need to know the common name? I'm going to say the common name. I'm going to say, I'm sorry, the generic name. So the where you see it says drug, that's the generic name. Ampicillin, amoxicillin, cephalosporin, clindamycin, penicillin. Those are fair names because the thing about a trade name is ampicillin can have many different trade names, okay? But one of the concerns is for antibiotics is a change in the gut flora, which happens to the lactating parent usually, and also it could happen for the infant, and also antibiotic resistance. Next slide, please. All right, moving down to antifungal. These drugs are used most commonly for something called thrush, which is an oral infection usually that an infant can get or someone that's immunocompromised, such as someone that's on chemotherapy. One of the key things to remember that if an infant is diagnosed with thrush, also known as Candida albicans, it's that both the mother and the infant should be treated simultaneously at the same time, as that can pass back and forth, and sometimes it's not as easy to clear up. Topical antifungals such as nystatin or miconazole, they're also used to treat yeast and are considered safe as long as minimal amounts are applied to limit the absorption to the infant. Let me make sure I go over. Yep, next slide, thank you. So analgesics. Remember I said analgesics is another one of the most common medications that lactating people will ingest, right? Particularly after delivery. And if depends on what type of delivery they have, that also depends on the medication that they may be prescribed. So with that being said, there are some combination medications such as combination of acetaminophen and codeine, which is typically called Tylenol 3. There are some Tylenol 4s. And the 3 just depends on the amount of codeine that's in the medication. What I will say to this is that I still see Tylenol 3s being prescribed. Tylenol in itself is an L1, okay? But codeine is an L4. The L4 classification is one that indicates that it's possibly hazardous. And the reason for that is because there are few people with a genetic trait that make them very rapid metabolizers of that codeine, which can sometimes impact the lactating parent as well as the infant. There are a number of studies that have had some adverse outcomes due to Tylenol codeine. So the FDA and numerous drug advisory groups recommend that codeine should no longer be used during lactation. Okay, Motrin is a non-steroidal anti-inflammatory, which is an L1. That's also a common medication that you may see. Aspirin also is an L. Do I have aspirin on here? I want to say I may have taken that off. Yeah, I don't see it. Okay. All right. So I'm not going to even confuse the
It's
situation.
there. You put
Is
it.
it?
Acetylsilic acid, aspirin, and
Okay.
ephedrine.
Okay, yes, yes. So this is one to not use if the infant is sick, or it's not to not mom can use it. I'm sorry, the lactating person can use it. But it's associated with Reye syndrome. So if the infant is sick, the lactating person wants to stay away from it. Morphine is also, it's a potent analgesic. It's also one that can be used for someone who's had a C-section. It's classified as a L3, and it you sorry, my words and my notes are jumbling up here. So you want to just be careful. Usually morphine is used in the hospital setting. It typically it is not prescribed once a lactating person goes home. But some of the common concerns as it regards to the infant is sleepiness and poor feeding. So you have those babies that just don't want to wait to feed. And sometimes it could be due to the morphine and the amount of morphine that's being given. Please note that the safety of the medications that are listed above are safe as long as they are being used as prescribed. When we're talking about opioids, we know we're in somewhat of an opioid crisis in this country. So they're safe as long as they're used as the prescriber has prescribed them. Next slide, please. Anti-seizure medications, if you think about it, anti-seizure medications are medications that targets the central nervous system. So when we're talking about these drugs, they're L2s, L3s, L4, Depakote. That is, again, potentially hazardous. But the rest of them you want to read. But the biggest thing to know about these drugs is, again, if they reach the central nervous system, they can cause sleepiness in the infant, poor feeding, and also irritability. Next slide, please. Antidepressants, before I go into this, I know there are we have an audience, a wide audience, that some have medical backgrounds, some don't. So I want to say this, there is a lot of research going on about antidepressants, but as for now, HEL says that Paxil, Zoloft, and Prozac are all L2s, which are safe. The concerns with these drugs for infants is it can cause infants to be sleepy, poor feeding, and think about when I'm saying these concerns, think about the concerns. They all have some things in common: sleepiness, poor feeding, if you want to really kind of see if there's a pattern here. But with this class of medications can also cause low muscle tone, agitation. And then if the person was taking it during pregnancy, sometimes the infant can display some withdrawal symptoms. So they appear to be safe. And I say to this, when we're talking about risk benefit, it's better for a person who suffers from depression to take medications so that they stay safe as well as their baby stays safe. Next slide, please. Antihypertensives. Um, I tried to put this slide in a way where you could see the L2s are all at the top for the most part. There's only one other L2 hanging out below. So these are medications that are relatively safe during breastfeeding and chest feeding. However, there's an asterisk at the very bottom, and that medication is called hydrochlorothiazide and furosemide. And the important thing to know about those two drugs is they're called diuretics. So they're pretty much, if you hear people say, oh, those are water pills are typically not to drink water, but to get the water off of people. So people who have tons of fluid. And sometimes we in the healthcare system give tons of fluid during delivery. So in saying that, sometimes a person may have been prescribed this before going home, or even maybe going home if they have some high blood pressure issues. Those two medicines, if you see there's an asterisk, has the potential to reduce milk supply. So you want to keep those in mind. Okay, but infant monitoring consists of, again, that sleepiness, that poor feeding, pallor, which is really like a palish color of the skin, and a lethargy. Next slide, please. Vaccines, as a general rule, they are safe. However, there's a couple caveats here. There's a caveat. Yellow fever during lactation is never recommended, so that one is not recommended. However, I want to talk about smallpox. So, according to Lawrence and Lawrence, which is one of the textbooks that we refer to, and this is the breastfeeding, a guide for the medical profession. This is the 8th edition. Okay, on page 402, and I'm saying this, I'm real intentional with this language for a reason. It says smallpox vaccination is inadvisable for the mother of any infant younger than 1 year of age, nursing or not. The personal contact, not the breastfeeding, causes the risk. Therefore, no advantage exists to weaning if vaccination is necessary. So this vaccination is not routinely given and is rarely indicated, but there you have it. There's the information regarding the smallpox vaccination. I will delay on talking about COVID-19 and vaccination. I know some people want to just chime on in, but I can say that it's so new that you probably don't even need to know that for the exam. All right. So next slide, please. Angela, take it away.
I will. I just have one comment,
Yes.
and I know that Kim and Julie are trying to find the answer. So maybe if you can look at the answer as well. Somebody had a question about pH. If you can explain how pH of a medication affects how it is transmitted into human milk, that would be wonderful. So I'm going to go ahead and start talking. And if you want to find the answer to that question, and we can type it into everyone, and then we'll read it at the end, just so that people are aware. So thank you very much, Sekeita. Okay, great. And so now, here we go. As I said, I'm Angela, and I really wanted to focus on, and again, taking a look at this broad overview. When we take a look at the IBLCE detailed content outline, I wanted to go over some topics which you may not have seen in your practice. Granted, if you work in the community, if you're with a breastfeeding support organization, you've seen older nursing babies, and you've seen sort of that normal course of breastfeeding. And remember, the IBLCE exam is international, as well as it covers the entire course of breastfeeding, which can be several years. And so I wanted to get into some of the older baby concepts and issues. And so that's where we're going to go with this information. So frequency and technique changes. So when counseling clients with older nurslings, be mindful that the number of feedings and time at the breast may fluctuate greatly. Babies might return to intense breastfeeding to adjust their parents' milk production as needed, which is sometimes referred to as growth spurts. They often occur around 2 to 3 weeks, around 6 weeks, and again at about 3 to 4 months. Now, this coincidentally corresponds with a shift in the maternal hormones with the gradual transition of endocrine to autocrine control of milk production. Developmental milestones may increase night waking and nursing. These little ones seem to be too busy during the day exploring to spend time at the breast. So they may miss something if they do spend time at the breast. Therefore, they might wake more frequently at night to receive the caloric intake they intrinsically know they need. Latch and positioning technique is considerably more flexible after the first few months. Note in the picture here that in the top picture that the baby is further away from the breast than when the baby was a newborn. Unless the parent is uncomfortable, there's no reason to suggest changing the position or the latch. Breast and nipple pain are two challenges that some mothers face while lactating. This picture here is one portion of a 13-page algorithm developed by the University of North Carolina for breast and nipple pain. It's a very valuable resource and a good review prior to the exam for how to identify the many causes of breast and nipple pain. Now, you don't have to jot down this URL so quickly. If you take a look in the handout section, this is actually one of the slides which is included in the handout, so you'll have that URL in the slides as the handout. So the next issue to talk about when weaning or when nursing a baby, and it can definitely happen during weaning as well, is mastitis. So remember, mastitis is an infectious process in the breast that produces localized tenderness, redness, and heat, together with systemic reactions of fever and malaise. Prospective studies estimate the incident to be between 3 and 20%, depending on the definition and the length of follow-up postpartum. Technically, mastitis is an inflammation of the breast, which may or may not involve an infection. The problem can begin with engorgement, then non-infective mastitis, followed by infective mastitis, and to abscess if treatment is not introduced promptly. Symptoms include fever of 38.5 degrees centigrade or 101 degrees Fahrenheit. And just to note, for the exam, they will actually include both the centigrade as well as the Fahrenheit with temperatures and kilos as well as pounds for the weights and measurements. Symptoms also include chills, headache, flu-like body aches and symptoms. The breast is swollen and painful. The breast area may look inflamed or red, or as you can see in this picture, I intentionally chose this picture so that you could see mastitis in someone who has a darker melanated skin. And because it can be kind of challenging to note the inflammation or the redness when you have someone with melanated skin. And so that's why I intentionally chose this picture. You may see streaks or bruising of the breast tissue as well. So what's the best treatment for mastitis? The first thing is rest. Continue to feed and or pump on the affected side. Warm compresses can help. Creative nursing positions. So we know that if the parent or if the baby is able to, if the parent is able to navigate the baby so that the baby's nose or chin is pointing towards that area where the blockage is or where the mastitis is, the baby can actually work out the mastitis or the plug a lot better than, let's say, a pump can. And so getting really creative with the nursing positions can help. Support compliance if antibiotics are prescribed, and use analgesic anti-inflammatory for discomfort, fever, and swelling. So recurrent mastitis is something which is a little bit more persistent. It's usually Staphylococcus aureus, according to Dr. Lawrence in her book, Breastfeeding: A Guide to the Medical Profession, as a common cause of breast infection. Jimenez in 2015 found that Staph aureus dominated the microbiome of mastitis sufferers. However, Staph aureus was found by Kvist in 2008 and Tina in 2016 in the milk of asymptomatic women. In the case of recurrent mastitis, the causes can include delayed or inadequate treatment of the initial disease and continued milk stasis. The diagnosis can be made with a culture of the milk and an infant nasopharynx or oropharynx culture. Treatment options and a thorough discussion of mastitis can be found in the Academy of Breastfeeding Medicine's protocols, number 4 to be specific. So do take a look at the ABM protocols, not only for mastitis, but also for almost any other topic. Their protocols from the Academy of Breastfeeding Medicine are evidence-informed, they're cited, and they're reviewed every 5 years. So they really are one of the best resources that you have when reviewing different protocols on how to deal with different issues. Okay, so here we have a breast abscess. So now a small percentage of breast infections will develop into an abscess. Kinley et al. In the late 90s reported the incidence to be about 5 to 10%, whereas Amir in 2004 reported 3% of women with mastitis in their sample developed an abscess. One theory is that healthcare providers are more educated in the prevention of abscesses now than they were in the late 90s. Dr. Lawrence reports an increase in abscess rate when antibiotic treatment was delayed beyond 24 hours. An abscess is a localized collection of pus that forms from an infection that has no opening for the drainage. The indications for an abscess are the same as mastitis, although the symptoms may be less severe because the abscess is isolated from the rest of the breast. This picture demonstrates an obvious abscess. Occasionally, an abscess can occur in the absence of any systemic symptoms. And I actually worked with a client who her initial abscess, which actually turned out to be MRSA, was on the breast, and it didn't have some of the stark presentations that you would notice in a lighter skin tone. but it was a slight discoloration of the skin, and this person was afebrile, but you could see, and then the abscess began to form, and you could definitely see that that's what it turned out to be. So as I mentioned before, Lawrence discussed that when antibiotic treatment is delayed beyond 24 hours, the abscess rate is increased, which is why encouraging compliance to antibiotic treatment is something which is suggested for lactation care providers. So different treatment options. For smaller abscesses, which are less than 3 centimeters, the recommended first line of treatment is fine needle aspiration, single or repeated, preferably under ultrasound guidance. For abscesses greater than 3 centimeters, a percutaneous suction catheter can be placed for 3 to 7 days with oral antibiotic effective against penicillin-resistant staphylococci for 10 days. For larger abscesses, the healthcare provider will incise and drain the area. A drain is placed to promote drainage. The incision heals from the inside out, usually within a week or two. The parent may continue to nurse on one or both breasts, depending on the location, associated pain, and medication. Okay, here we have a picture of a person nursing while they are pregnant. So whenever you are dealing with someone who is pregnant and is still nursing and finds out that they're pregnant, it's really important to explore the parent's feelings about continuing breastfeeding. Some people may note nipple or breast discomfort during the pregnancy. Some report the discomfort alerted them to the new pregnancy. Depending on the age and nursing relationships, some nurslings may be reluctant to wean. Mature milk changes back to colostrum at around 4 to 5 months into the pregnancy, which may change the taste and quantity of the milk, which may be that little extra push that the nursling needs in order to wean. So now remember that oxytocin is released during nursing. However, the oxytocin is blocked by progesterone. There is no need to wean a nursing baby or child unless there is a true risk of preterm labor. There's limited data which shows an impact on the mother's nutritional status by continuing to nurse through pregnancy. Therefore, it is important for the parent to be mindful of their diet. Some older babies and toddlers may stop during the pregnancy and resume after birth. So for those older babies who do resume after nurse, again, tandem nursing is the term which describes, I mentioned tandem nursing here, it describes breastfeeding of 2 or more children who were not born at the same time or are of different ages. It occurs when a parent nurses through their pregnancy, or if a previous child weaned during pregnancy, they may be interested in resuming. Explore the parent's feelings about tandem nursing. One of the pioneers in the lactation profession, Shelley Marmette, once said, "It takes the patience of Job to tandem nurse." Now, if there is an issue with the infant's weight in the early days, ensure that the newborn is giving priority at the breast. Some parents will dedicate one breast to the newborn and the other to the toddler and switch the next day. Note here the way the older sibling has her arm around her new little brother. Granted, it may be so that everyone can fit on mom's lap, but it also might be a very sweet sign of affection. If a mother expresses a desire to wean, explore their reasons. Some families believe that weaning may increase a child's independence or help a child to sleep more at night, which may not be achieved through weaning. Gradual weaning works best for both the parent and the baby. It reduces the risk of severe breast pain and mastitis. In several texts on nursing a toddler, the first suggestion is don't offer, don't refuse a child's request to nurse. So don't offer the breast and necessarily don't refuse a child's request to nurse. You can eliminate a feeding every 2 to 4 days, preferably not back-to-back feedings. So initially, if the parent decides that they want to try to eliminate that feeding, which happens, like let's say around noontime, then let's not make it the feeding which happens at 9 a.m. or the one that happens at 3 p.m. In other words, try to play around with it a little bit. It's important to continue this accommodation, this lack of nursing, as both the parent and the child can accommodate this new routine. Hand express for comfort is needed. Change the daily routine for the child so that the alternatives to nursing are offered and explored, and they're a lot more fun than sitting there and nursing. For example, I know some parents who will start to go out at that time when maybe the baby might be nursing to sleep. So they'll go out or they'll drive around in a car so that the baby gets tired and can fall asleep in the car as opposed to fall asleep during nursing. Offering other foods, drinks just before the regular nursing sessions may help to distract the child if indeed they are thirsty or hungry, as opposed to needing that nutrition at the breast. They possibly could get it elsewhere. And if you do, another suggestion for weaning is to breastfeed when asked, but for shorter periods of time. And you can even time those feedings. And I know a lot of parents will time those feedings, especially if they're pregnant and if they're experiencing nipple discomfort while they are nursing. Okay, great. So I'm going to keep going forward. Sekeita, if there's anything in the chat that you want me to address now, please do let me know. Feel free to interrupt me. Otherwise, the questions are being answered in the chat, and we will answer them at the end as well. Okay, milk supply. So now we're going to get into milk supply. So I just want to show you this picture. It may look very familiar. It is of the neuroendocrine reflex arc, and it's to remind you of the physiological mechanism of lactation. Milk synthesis is a very complex interplay of the hypothalamic pituitary gonadal axis. Milk synthesis is related to the degree of breast fullness. Suckling or expression or other nipple stimulation stimulates prolactin secretion and the release of oxytocin. It is milk removal that enables milk secretion to continue. So this is another slide you may have seen in one of our courses. We have it in our anatomy and physiology course, as well as the relactation course and exam reviews. So according to Margaret Neville and Jane Morton, failed lactogenesis can be described as preglandular, glandular, or postglandular. True failed lactogenesis can come from these three sources. An example of preglandular would be hormonal causes, such as retained placenta or lack of pituitary prolactin. Glandular causes might be surgical procedures such as reduction mammoplasty or possibly insufficient mammary tissue. Postglandular would be any cause for ineffective or infrequent milk removal. This would include iatrogenic causes of lactation failure, are those which are impacted by policies and procedures in hospital or by healthcare providers, which can have a negative impact on milk production. A parent's perception of milk supply in the early hours and days after birth could also be included here. It is a common perception that a sleeping or quiet baby is a happy baby. Parents may misinterpret baby's lack of settling post-feed as a sign that a baby isn't getting enough and supplement. Parents may interpret normal newborn nighttime circadian rhythms as a sign that a baby is hungry and assume lack of milk. So I mentioned postglandular. I want to just give a few other reasons for postglandular reasons for lack of milk supply or an insufficient milk supply. And I think because that's more ubiquitous. So I mentioned already the iatrogenic reasons of lactation failure, which is the separation of the parent and the baby, pacifier use, this perception of insufficient milk. Interventions which require supplementation and milk supply are not simultaneously supported through hand expression or pumping, which means if we intervene and we do need to supplement, we also need to make sure that we have milk expression going on. Consider the supplementation scenario when a parent is told they have to supplement their baby. They may feel in that very moment that breastfeeding has failed and they worry about resumption. Well-meaning healthcare providers may not encourage the resumption of breastfeeding if the interventions such as supplementation are being effective. So common scenarios in this situation could be a baby who's diagnosed with hyperbilirubinemia in the early days after birth, and we start supplementing with breast milk substitutes, or sometimes it can happen at around the 2-week visit when the baby isn't gaining effectively, and they do start to begin with supplementation. In both of these cases, the parents may be afraid to resume exclusive breastfeeding, and healthcare providers may not have the time to create a care plan to help the baby to return to exclusive breastfeeding. And then finally, there are some of those cultural beliefs that create a barrier to normal breastfeeding, such as colostrum not being enough or something which is bad for the baby. So structural issues. So here we have anomalies of the maternal breast. So you'll note here surgical interruptions such as a biopsy, reduction, augmentation, chest tube as a preterm baby or a thoracotomy prior to breast development, mammary hypoplasia or insufficient glandular tissue, breast asymmetry including intramammary distance or the space between the two breasts. Chronic illness can also impact milk supply. Hyper or hypothyroidism, lupus, Parkinson's, diabetes, hypertension. Acute illness or birth-related complications include hemorrhage after birth, especially causing large sudden drop in blood pressure and or requiring a blood transfusion. As a point of reference, 500 milliliters of blood loss is considered normal. Hemorrhage may cause damage to the pituitary, ranging from a mild insult to major infarction. Sheehan syndrome is a severe hemorrhage and drop in blood pressure that may result in necrosis of the anterior pituitary. Hormonal issues were referred to a few slides ago, and they're worth mentioning again here. So irregular menses, infertility, obesity-related issues, and PCOS. Weight loss surgery, specifically gastric bypass surgery, can impact the amount of nutrient absorption. Other factors which may cause a delay in lactogenesis 2, or those risk factors. Now, each one of these points I could go into in depth. If you have further questions about the specifics, please review your notes or the lessons or the literature. So other factors for delayed lactogenesis 2 include premature delivery, insulin-dependent diabetes mellitus or gestational diabetes. Metabolic status or health refers to an interesting study from Namsen, Rivers, Donnell, and Huang in 2012, and it describes 3 risk factors for delayed lactogenesis: higher BMI, increased maternal weight, and larger infant birth weight. Now, what's interesting is that those are also known correlates with carbohydrate intolerance and systemic inflammation, which could have an impact. That's the theory. Fat phobic bias and staff which are unaware of their bias. And we want to thank Kristen Cavuto for bringing this important concept to our attention. If you're not familiar with the concept of fat phobic bias, please feel free to reach out to me. My email will be at the end of this presentation. Feel free to reach out to me and I can provide you, or frankly, reach out to Kristen Cavuto in order to receive information about fat phobic bias. Delayed lactogenesis 2, more risk factors could be hypertension, high levels of stress to the parent and fetus during birth, cesarean birth, especially when it's urgent, prolonged stage 2 of labor, which is greater than an hour, augmentation of labor with intravenous oxytocin, forceps or vacuum delivery, the timing of the first breast stimulation following delivery, significant edema of the extremities, and endocrine disturbances. Complex interrelationships exist amongst the various factors that may affect lactogenesis. Whether the delay of lactogenesis 2 is a maternal physiological response due to delayed or ineffective suckling or a combination of factors has not yet been clearly identified. Early, frequent, and effective breastfeeding appears to be the most important factor in establishing normal lactation. I would argue that skin-to-skin and milk expression in the first hours after birth as key factors to counter the possible risk factors. Those of you who work in a hospital setting can understand how that might be impeded with any of the above diagnoses. Again, getting the parent to start milk expression within the first hour as opposed to 6 hours post-birth is crucial in increasing milk supply in those early hours and days and ensuring a sustained and a robust milk supply later on. Now, we can't just take a look at the gestational parent. We also need to take a look at the infant. And so any issues which may affect sucking or suckling frequency may affect the initiation and calibration, which is a term from Marcia Walker, of the milk production. The baby may not be capable of sufficient milk removal to initiate and maintain an adequate supply. Important factors include gestational age, premature infants, of course, but remember that those late preterm infants may not suckle well enough for adequate milk removal. The infant's oral and facial anatomy, any tongue mobility restriction that can impact not only the maternal nipple discomfort, but also the ability to remove milk. Palatal issues obviously include partial or complete cleft of the hard or soft palate, but also a high bubble or channel palate, and airway issues such as laryngomalacia or tracheomalacia. Long-term, the issues on the previous slide can impact the initiation and calibration of milk supply. The following can impact the maintenance of milk production. So immediate postpartum, we're looking at infant hypotonia or hypertonia, birth trauma, such as shoulder dystocia or the use of a forceps or vacuum. And that's the picture of this little one here. He had several failed vacuum attempts, and I believe this baby was born via vacuum, and it may not be as apparent, but his head is inflamed and you can actually see the swelling on his head, and those little black dots on his head are where they actually attempted to, where they were using an internal monitor on the baby on the scalp. So all of those things, and the reason why the mother was smiling, frankly, is because I asked if I could take it. This is a picture of mine, and I asked if I could take a picture, and I explained that I teach and that I wanted to show. And she was just so happy and so relieved after the birth. And indeed, she was an educator herself, and she said, absolutely take the picture. I want people to know that some of these things could impact milk production and can impact nipple pain and trauma in those early days. So cardiac or respiratory issues can also affect the infant's role on the milk production. Long-term impacts, again, can include infant facial anomalies, the tongue, the palate, and sensory integration issues. So now, what are some solutions to these problems? Well, as I mentioned, as I may have mentioned before, and I actually think I didn't, but I want to reinforce the fact that prenatal education can reduce the use of supplementation in the early days by parents who believe the baby isn't, quote, getting enough. During the hospital stay, frequent skin-to-skin contact, you really can't overdo this. Frequent colostrum or milk removal. Hand expression does seem to work best. A quick note for parents who are pumping for their premature infant or having trouble extracting an appropriate amount, the utilization of other senses can help with the milk ejection reflex. A study noted an improved milk output when the parent was looking at pictures of the baby and or listening to the baby's cry or coos, as well as smelling their t-shirt or blanket from the day before. And here we have a picture of a parent looking at pictures of her baby, listening to calming music. And actually I also think that they are listening to a waterfall, because that water movement seemed to be the trick for this parent. And so using the other senses can help with milk removal. Also, the anticipatory guidance of normal newborn circadian rhythms, being that babies are awake all night long, usually after the second or third night. Visuals of the newborn stomach and the nominal nutritional requirements in those early days. Realistic expectations for output. Alternative supplementation techniques if required, and really strong follow-up after discharge, after the birth, and of course after discharge as well. Okay. I'm going to take a moment, take a breath, because now we're going to dive into variables and experimental study. One of my favorite subjects. Okay, so here just a brief overview. We have the dependent variable, which is what the independent variable acted upon. So the dependent variable is the outcome and the response the searcher wishes to explain. In a study on breast pumps, the volume of breast milk obtained when using several types of pumps was compared. The volume of milk is the dependent variable. The type of pump is the independent variable, or that is the intervention of the treatment, and what is manipulated to cause an effect on the dependent variable. Now, confounding variables in this example might be the privacy of the place the parent used to pump. That might lower the amount of milk they're able to extract, or the time of day could also be a confounding variable. So it's important when you're reviewing research in general, but also in regards to sitting the exam, that you take a look at anything which is listed in the stem of the question, or in the actual question itself. That's called the stem. So now I just want to review some terms which are frequently used here. So range is the top and bottom score. The mean is the average of all of the scores. Median is the middle number. The mode is the most common or repeated number. And then standard deviation. So standard deviation is a measure of how spread out the numbers are. And when we take a look at this, well, let me actually go back to that. 68% will fall in the first standard deviation. 95% will fall into the first and second standard deviation. And 99.7 will fall into the first, second, and third standard deviation. And there's only going to be a few in the fourth standard deviation. This slide is in your handouts. Then we want to take a look at statistical significance. So that is the level of certainty in the results of a study. If we want to be 99% confident of our results, we set the significance level as 0.01. If we want to be 95% confident in our results, we set the significance level at 0.05. And that's where most medical research, that's the standard that most medical research uses, is 0.05. Now, bias. There are different types of bias and it can influence research. For example, a piece of research looks at the effectiveness of a breast pump, specifically the frequency of the number of cycles per minute. You note the university who supported the research is funded by a specific breast pump company. The researcher whose university received the funding from that pump company could be biased in their study design and or the interpretation of the results. So it's important for you to take a look of those pieces when you're actually reviewing the research. Informed consent. So that is that subjects need to be informed about their rights, equipment, and medications utilized prior to the study. They also need to be aware and told about the procedures, confidentiality, and how to withdraw from the study at any time, as well as any rewards for participation. Okay, so now it's question time. And so these are the questions for you. And so we are going to, in just a moment, we're going to put up a poll. You're going to be able to answer in the poll. We'll give you about 10 or 15 seconds to take a look at it, which seems quick, and it is quicker than the exam. But let's see what sort of results we get with taking a look at this. And it may be a little longer than 15 seconds. I don't want to say it's only going to be 15 seconds. So here we go. All right, let me get the first question here. So Steve, I think, has put up that poll already. And the question is, physical breast presentation may contribute to low milk supply. Why? So which physical breast presentation may contribute to low milk supply? Sorry. Intonation helps. So significant intramammary fold, breast cup size of B, less than a B, significant intramammary distance, or hypoplasia of the superior breast tissue. Okay. And we've actually given Steve popped that poll up a little early, so we've actually given you 45 seconds to answer. All right, and we close the poll. And 66% of you said the significant intramammary distance, 32% said hypoplasia of the superior breast tissue. And so remember where the superior breast tissue is, right? Check me, Sekeita. The superior breast tissue is going to be, sorry, I shouldn't do this, it is going to be on the top. Okay, so the superior on the top, that doesn't bother us as much, especially if we've got a larger breast, because ptosis can mean that there doesn't appear to be much breast tissue in that upper aspect of the chest or the breast. And so that's not going to be it. So now some of you may say, well, wait a minute, that's cheating. You guys tricked me. Read the question, read the answer. And so significant intramammary difference. Remember I said that if we have two breasts, that the spacing between both of those breasts, that's what can be the sign that there could be insufficient glandular tissue in those interior portions of the breast. And that's going to be the medial portions of the breast, right, Sekeita? Okay. Okay, Sekeita, all right, thumbs up from Sekeita, so I know I got it right. Okay, good. So, see, this is why Sekeita and I do this together. We check each other. Okay, going on to the next question here. Thank you, Steve. So, a postglandular reason for insufficient milk production is early introduction of hand expression, pacifier use, retained placenta, previous breast biopsy with a periareolar incision. Postglandular reason for insufficient milk production. Y'all are doing good on this one. I don't know if you can change your answers or not. The way things are moving, I kind of feel like you can. So this is a postglandular reason. Okay. Go ahead, Steve, close the poll. So yes, the answer is pacifier use. 67% of you chose pacifier use. Postglandular would not be the retained placenta, nor the previous breast biopsy with the periareolar incision. So note that that previous breast biopsy with the periareolar incision, that's called a sophisticated distractor, right? Because we're looking, they had breast surgery. That periareolar incision, if they cut that fourth intercostal nerve, then that's what it is. But no, it's not. That is not a postglandular reason for insufficient milk production. Okay, great. Okay, we're going to move on to the next question. All right. Now I'm going to read this because I had to shorten it up when I actually put it in the poll, so give it just a moment. While reviewing your postpartum patient's chart, you see they received Pitocin or synthetic oxytocin and Methergin. Methylergovine, I didn't practice. Methylergonavine maleate after a vaginal delivery. You know this patient most likely will experience normal blood loss, experience excessive blood loss, gave birth to multiples, will not be able to breastfeed. Okay. So while reviewing your postpartum patient's chart, you see they received Pitocin and Methergin after a vaginal delivery. You know this patient will most likely. Okay, great. We're going to go ahead and close the poll. I think most of you got it, which is experience an excessive blood loss. So they utilize 2 medications, and both of those medications are utilized whenever we've got a postpartum hemorrhage. And so the fact that you just note those 2, yes, they could have given birth to multiples, but it probably wouldn't have caused an excess of weight loss, of blood loss. And so that's the reason why you would know that it was an excessive blood loss. Okay. Moving on to the next question here. And again, I had to shorten this one as well, so I'll go ahead and read it. Lilo Lactation Consultant did a study in their hospital where they surveyed the parents' duration of breastfeeding. They found the range was 1 week to 18 months with a mean of 8 months. What type of research is this? Quantitative, qualitative, historical, epidemiological? I can say that word. Okay, give you another few minutes here. Come on, go ahead and vote. Don't be shy. If you can, take a look on your mobile device or on your computer. Okay, Steve. So yes, the answer is quantitative because it's based on data. It is not experimental and it's not an attempt to determine causality. So it is qualitative. Okay, going on to the next one.
Angela, you meant quantitative, right?
Yes.
Okay. You just said quantitative first and then you said qualitative second. So I'm just want to make sure.
Thank you, because every single person who just heard me say that just said, what did she say?
Yeah.
So, okay, thank you. Yes, it was quantitative. Thank you. All right, next question is, there we go. Lilo, thank you, Steve, already started collecting responses. Lilo Lactation Consultant did a study in her hospital where she surveyed patients about their satisfaction with breastfeeding and what type of problems they encountered. What type of research is this? Quantitative, qualitative, historical, epidemiological? See, I'm not going to fool y'all this time. Okay, Steve, thank you. Yes, the answer is qualitative. And so remember that qualitative research, exploring reality based on perceptions, consider multiple perspectives, no attempt at causality. Quantitative research is based on data collection and analysis, it's experimental, and it's an attempt to determine causality. Okay, great. Now, moving on to the next question. A few more to go. Iron levels are low in breast milk. What instruction should parents be given? A is supplement with iron drops until the baby begins solid foods fortified with iron. Breastfeed, no supplementation is needed. C, breastfeed and supplement at 6 months with iron fortified foods. D, increase the amount of iron in the parent's diet to increase the amount of iron in the breast milk. Okay. Good. 60% of you have voted so far. Excellent. Don't be shy. Okay, thanks, Steve. So now, as much as we would like to say that additional iron intake by the parent should be sufficient, it's not. And so indeed the parent's body processes the foods and the nutrients and utilizes them for themselves. And granted, it will support lactation, but not enough of it is going to actually get into the breast milk in order to help the baby. And so that's the reason why increasing the amount of iron in the parent's diet won't be effective. And then also breastfeed, no supplementation is needed is actually inaccurate as well, according to several organizations which study this topic around the world. So iron supplements we have seen actually may produce constipation in the baby. And so we want to be mindful of that as well. Okay, moving on to the next question. The next question is on vitamin D. Okay, vitamin D levels are low in breast milk. What should be done? Supplement the baby with vitamin D until solids are started. B, breastfeed, no supplementation needed. C, breastfeed and spend a half hour daily in the sun. D, baby should be supplemented with 400 IUs of vitamin D daily. You know, it is so funny as I see you all answer this question. This is my favorite part, Sekeita. We have to have polls in every single one of our webinars. I'm just saying right now. And the reason why is because the answer to this question has changed over time in that what people know about what should be done. And so it's interesting to see that we're not really fooling you much.
Can you give the breakdown just of, the percentage of who answered what? Thank
Absolutely.
you.
So we have 77% of people who voted. Go ahead and close it out, Steve. And we have 75% who chose D, which is the correct answer. The baby should be supplemented with 400 IUs of vitamin D daily.
Okay.
The second response was supplement baby with vitamin D until solid foods are added. And the reason why I would say that may not necessarily, until solids are started, the reason why that one may not be accurate is because baby should be supplemented from the beginning. And note that there's a specific amount, that 400 IU, that is the answer. And so notice that the first one didn't say to do that, didn't give the specific number, and then it also said until solids are started. So then you could possibly, in theory, not utilize vitamin D supplements after that. But the answer is you do still need to use vitamin D supplements. And the third answer was to breastfeed and spend a half hour outdoors daily. So here's why that answer isn't correct. 9% of people said that. Because where are you in the world, right? If you live in Finland, and if you live in Tanzania, or if you live in Ecuador, okay, or Vietnam, right? How much sun you get is going to be different. Plus, we're very mindful that we don't want certain types of skin cancer, which can be started early on, to put the baby at higher risk, right? And so that's why we avoid saying to go outside and spend a half hours a day. Now, is that sage advice? Yes. And that's something though, which is good information to give when you're one-on-one counseling someone, because you do want to have that conversation about sun safety and making sure that the baby is covered. And it's actually in the shade that a baby can actually receive some of the vitamin D, but how much time they would need to spend outside is going to vary greatly depending upon where in the world you live. And there's the reason why answer D is the best. Okay, great. Next question. Okay. This is going to be one of your favorites. How old is this baby? And so in the poll, it says, is this baby 2 weeks old? Is the baby 4 months old? Is the baby 2 months old? Or is the baby 8 months old? And you may be looking at this slide and saying, are you kidding me? And so that's the reason why we included it. And the reason why is because take a look at the picture and take a look at some of the cues. What are some of the things that you see in that baby? All of the information is in that picture. And I will say that it is a little deceptive. Thank you for closing out the poll. It is a little bit deceptive. So the answer is, well, let me actually give you some hints first, okay? So one of the hints we have is that the baby has a social smile. The baby can lift their head at about 45 degrees. The baby holds the head up for a few seconds. So the question is whether or not that's sustainable. And so then we want to take a look at some of the other cues about how high that baby's head is lifted. And it looks as if, because the baby is smiling, it looks as if the baby has found the familiar face or the sound that they were looking for because they're smiling, right? And so when we take a look at all of this, the answer actually is the baby is 2 months old. So 35% of you said 2 months, 58% of you said 4 months, 2% said 2 weeks, and 5% said 8 months. And so, this little one is showing how they can hold their head up and begin to push up a little bit while lying on their abdomen. So at 2 months, they may not be able to sustain that pose, but the parents are at her level. So notice that the parents, are obviously down close to that soft surface that the baby is on, and they're taking a quick photo to show strength. So those are some of the cues that you would want to take a look at. And indeed, 2 months and 4 months, I can see where the confusion is there. And so just stop and take a few moments. Also note that the baby's hands are clasped in fists. And so the baby is utilizing quite a bit of effort. Also, you can try to see how long that baby is. This could be a baby of short stature, right? Maybe a petite baby. But you just want to kind of take a look at some of those cues. Okay, getting almost done to the end, almost to the end here. Okay, on this question here about viruses. So which of the following viruses is most likely to be transmitted to the infant through breast milk from an infected parent? A, hepatitis C, B, herpes simplex virus, C, varicella zoster virus, or D, cytomegalovirus. So which one of the viruses is most likely to be transmitted to the infant through breast milk from an infected parent? Take a few minutes. Think about it. Through breast milk, infected parent. Now, if you don't know the answer, it's okay. Go ahead and guess, but about 75% of you have voted. We got to 80, almost 80, good. Okay, so the correct answer is D, cytomegalovirus. So CMV transmission from parent to infant occurs in 60 to 70% of breastfeeding dyads where the breastfeeding parent is infected with CMV. However, healthy infants who acquire the infection in this manner are almost always asymptomatic, and breastfeeding should be encouraged. Premature infants and immunosuppressed infants are at higher risk of complications from CMV infection, and there is debate about whether these infants should receive CMV positive breast milk. So 47% of you said CMV. Herpes simplex virus and hepatitis C are unlikely to be transmitted via breast milk. And varicella zoster virus causes chickenpox and zoster. Infected parents should be encouraged to breastfeed. The infant should be protected from direct contact with skin lesions, and the same is true with the herpes simplex virus. So 47% of you said CMV and 39% of you said hepatitis C. So just know that hepatitis C is unlikely to be transmitted via breast milk. Okay, great. And so just 2 more questions here. So on this question, Tyler is a vegan. What would you suggest to ensure adequate nutrition for the parent and baby? A, protein from beans and rice. B, minerals such as magnesium and selenium from grains. C, folate from dark green leafy vegetables. D, B12 from fortified foods or supplements. Okay, half of you voted. Oh, good. This is turning out to be an easier question. I'm happy to see that. The nutrition, we must have a lot of nutritionists in the crowd today, Sekeita. They're catching all these. Okay, I think we can go ahead and close the poll. The correct answer is D, B12. So 86% of you chose D. And the reason why is vegan diets include no animal products, which are the only dietary source of B12. To avoid a B12 deficiency, vegan nursing parents and those who consume very little animal protein need to take steps to make sure they receive vitamin B12 either from foods enriched with B12 or taking regular B12 supplements. So the second most common answer from everybody was 9% of you said protein from beans and rice. And so indeed, we do think that, you know, these parents need protein, but actually it's the B12 piece that's more important. Okay, good. And now I believe, oh no, we have 2 more questions. Sorry, I thought we were getting closer to done. 2 more questions. So, and I know y'all are having just as much fun as I am. So here we go. This question, the primary reason for supplying breast milk for premature infants is to A, improve bonding between breastfeeding, chest feeding parent and baby. B, assure continued breastfeeding, chest feeding after discharge. C, prevent necrotizing enterocolitis. D, improve neurological outcomes. So the primary reason for supplying breast milk for premature infants. What is that primary reason? And the word primary is important in the STEM because frankly, all of them are true. So it's the primary reason. Okay, good. About 80% of you have answered and 80% of you chose the correct answer. 80% of your 80% chose the correct answer, which is D, preventing necrotizing enterocolitis. 12% of you chose D, improving neurological outcomes, which is true, but it's not the primary reason. And then 3% chose improved bonding, and 5% chose assure continued breastfeeding or chest feeding after discharge. Okay, great. Next question. The risks of skin-to-skin care in newborn infants include respiratory instability. So the risks of skin-to-skin care, respiratory instability, sudden unexpected postnatal collapse, hypothermia, sudden unexpected infant death. So the risk of skin-to-skin care in newborn infants. This one's a little tougher. I would say that something like this might be on the exam just because the answer is something which the conversation started probably about 8 or 10 years ago about this phenomenon, and it's being more and more recorded and noted. Okay, Steve, I think we're good. 75% have answered and 68% of you got it correct, which is sudden unexpected postnatal collapse. And so SUPC is something which is, it happens in the hospital and it happens in that first week after birth. And it's usually a baby who's born with good APGARs. And there doesn't seem to be any other reason why. So that's why it can kind of be confused. 13% of you chose sudden unexpected infant death. But again, the specific question asked for risk of skin-to-skin care. And so it wouldn't necessarily be sudden unexpected infant death if it was skin-to-skin care, but that postnatal collapse. And if you'd like to learn more about this, I actually did not include this in the handout, but you can definitely do a search for it. Sekeita, were you going to say something about SUPC? No.
No.
But there's a toolkit. Susan Ludington-Ho, who actually was one of the founders of the whole research on skin-to-skin care, is actually the one who made the call to action for this and created a protocol as well in order to discern and to make sure that babies and parents that the baby is safe. The third most common answer you chose was hypothermia, that means the baby's too cold, and so that's not a risk of skin to skin because if we keep the baby on the parent's chest, they should stay warm enough. And respiratory instability is not correct because it improves respiratory stability. So, okay, good. All right, here we have a picture, which is great. And so take a look at the picture before Steve pops open the poll. Couldn't put a picture with the poll with GoToWebinar. This technique is useful for all infants except premature infants, Down syndrome infants, neurological impairment, infants with type 3 ankyloglossia. So this technique is useful for all infants except So notice that it is a negative stem. And while we usually say, well, IBLCE tries not to include negative stem questions, indeed, every now and again they do. And so that's why we kept this one here. Okay, Steve, we've got about 80% of people who have voted, and the correct answer is D, infants with type 3 ankyloglossia. So this is known as the Danner hold, and you can see I'm actually doing it here. And so what this does is it actually improves the intraoral pressure that the baby is able to provide when trying to get milk out of the breast. So notice that we've got two things happening here. One is that we've got the straddle hold. So you can see that the parent and the baby are tummy to tummy. So the baby's legs are on either side of the parent's thigh. And so this would be utilized in premature infants. It would also be utilized with Down syndrome infants and babies with neurological impairment. So all of those things are going to help to stabilize the jaw and help with that intraoral pressure and help the baby to extract milk a little bit more effectively. So 69% of you chose the correct answer, which is infants with type 3 ankyloglossia. 19% chose premature infants, 5% said Down syndrome, and 8% said neurologic impairment. Okay, great. And now really this is the last question. Okay. I'm just going along here, so I do apologize.
You're tricking us. You're tricking us. That's okay.
I am. Because I know you all like these questions, okay? This is really good. It's a really good practice. So the World Health Organization guidelines for preparing powdered infant formula, PIF, recommend boil the bottles and teats for 20 minutes, a rolling boil. Boil the water used for mixing for 20 minutes, a rolling boil. Mix the measured amount of powdered formula and hot water, and that temperature being 70 degrees centigrade or 158 degrees Fahrenheit. Store prepared bottles in refrigeration for up to 72 hours. Okay, so World Health Organization guidelines for preparing powdered infant formula. What is that recommendation? Half of you have voted. Got 60% now. Okay, Steve. Even though 75% of you have voted, it's been a minute. And so the correct answer is C, and 53% of you got the correct answer, which is mix the measured amount of powdered formula and hot water. So that number on the temperature of the hot water is important. The reason why, 30% of you chose B. And the reason why that's not correct is because it is the 20 minutes, boiling the water for 20 minutes is not correct. So the rolling boil is not correct for 20 minutes. And that's also why A is not the correct answer. So 11% of you chose A. And boil the bottles and teats for 20 minutes, that's not accurate either. I believe it's 5. And with the hot water, you're to get the water to that temperature, and usually it's right when it starts to boil. That's usually when you've hit that 70 to 158, 70 centigrade and 158 Fahrenheit. And then the reason why D, 5% of you chose D, that's incorrect because the answer is 48 hours, not 72 hours. So you can prepare powdered infant formula ahead of time, and you can store it in the refrigerator for 48 hours. Okay, great. So I'm going to go take a look at the questions and hear all the people talk about the questions and how we can improve the questions. And so while I do that, Sekeita, how would you like to tell everybody some really good suggestions for exam day survival?
I'm going to jump into that. I want to go reference something on the previous poll question about the 158 degree. And I want to just add a little tidbit that is the temperature at which once the water hits the formula, it kills Chronobacter. So I wanted to just add that in there just so that you understand the rationale and why a question may be formed or the answer may be formed the way it is. And so, all right, so Angela just went over a lot of information, a lot of information. And I know that right now you're probably feeling a little bit like, ah, especially after those questions, right? Because I think I was sitting on the edge for you all, but it wouldn't let me answer any. So right now I'm going to ask you to just take a deep breath, a cleansing breath. Just take a deep breath in and relax. And know that it's almost there. It's almost. So we're going to get into some things to prepare. And this is more of the practical stuff, right? The practical things. So this is no more content, practicality. So let's go. Next slide, please. Is the slide not advancing? Got it. All right, so you've made it. So first thing, you took a deep breath, and I'll just clap it up, clap it up, clap it up, clap it up. Yes, give yourself a hand. In all seriousness, serious, that word, that's what I'm talking about. So preparing for the IBLCE exam, it requires passion, it requires dedication and endurance. I'm not gonna even, I'm just gonna keep it all the way real. Most people have lives, and you have prepared for it, not only doing life things, but during a pandemic. That's huge. I am not going to pretend that I know what that must be like. And so the fact that you are here with us right now, preparing, getting these extra nuggets, just it says so much about your passion and your dedication. So when the day of the exam, that's what I want you to remember. I want you to, if you're either taking it at home or if you're taking it on the at a testing site. And the reason why I'm saying that is because we do have an international audience. There are some that will be going to testing sites, and there will be some that will be doing the live proctoring. But arriving at that day, I want you to remember your dedication, your endurance, and your passion. That's what got you here. So that morning, you want to wake up, you can make sticky notes, you can make whatever. Those are the key things you want to remember to kind of ground yourself in the purpose. And so, because if you don't have an intention or a grounding moment, you wake up and the exam is like this and you're like, nope. Give yourself a hand and remember why you're here. Next slide, please. So while you're preparing the last few days, we've discussed a lot of key areas. If you found that during your preparation, there are areas that you really need to focus in on and key in on those things. Don't go over and over the things you already know, right? You want to focus on the things that you need to brush up on. So again, celebrate your dedication, be proud of your endurance, and trust in your preparation. Next slide, please. Remember to breathe deeply. When you are answering questions, it is sometimes very, you want to second guess yourself. If you get to that point, take a deep breath, reread the question, answer the question. It is to your benefit to answer every single question. Don't skip a question and say, I'll come back to it. What you can do is answer it and flag it. Okay, next question, next slide, please. All right, so before the exam day, you should receive a confirmation email. And you're going to receive lots of information on computer system requirements, and you may have already received it. Those sorts of things. So we're in this space of texting and short reading and skimming. I'm going to recommend that if you do nothing else, you read every single word. You test you look at what the computer system requirements are. The fact that you can't test on a tablet, that you can't use your mobile hotspot, that you need a stable internet connection. These are all the things. The security measures. What do you do for breaks? Those can all be found on IBLCE's website. I can say that this is now what the second round of testing in a pandemic. And what happened with some people the last time they took the exam is getting up to go take a break without it being during an official break time. And then that was, so you don't want to get to this point and not be able and be disqualified from taking the exam because you didn't understand that was not acceptable. So those are the things I'm going to, and I'm going to dive a little bit deeper into some of the computer system requirements, just so you have an idea of really how detailed you want to be looking at any information that comes to you regarding your exam and requirements from Prometric, if that is the testing site, or live proctoring site, or if you have to go in person. So you want to be reading all of it. Next slide, please. So regarding the Premature computer system requirements, it's important that you understand the recommendations that they have set out for testing on testing day. So your screen resolution has to be a certain number, and this is the number that's on their website. And I actually reaffirmed this earlier this morning because I wanted to make sure that nothing changed. So as of now, the operating system has to be Windows 8.1 or higher, or Mac, it has to be 10.13 or higher. The web browser that they recommend is the latest Google Chrome. So what that means is, when I say latest, it means have you updated. Make sure you've updated your computer system or laptop or personal PC or Mac, however you want to describe it. Your webcam resolution has to be to this specification. You have to ensure that you have working speakers and a microphone. Those are required. And your internet speed should be 0.15 megabytes per second or greater. Now, in saying that, there is a way to test. So your system, meaning the speed, there's a way, but also the systems check there on the website for IBLCE's frequently asked questions. There's a link, and you click on it, and it'll test your to see, are you ready? Is your system ready for? And then you'll know what to do. The other thing is what if you start to have technical difficulties? I am posing these questions to you not to answer every single one, but to say these are things that you probably want to know before diving in. When we were doing our tech check, I said to Angela, I said, hey, they're doing constructions outside of my house. I'm plugged into the Ethernet. However, just in case we get disconnected because they're digging in the grounds, I don't know. I want to make sure that you all know what's going on. Those are the types of things that you want to know. What if that happens while you're taking an exam? First of all, that would be just anxiety provoking. But if you know in advance what the steps are, then that does minimize the anxiety. It keeps you focused. It gives you a plan, and you know what to do. So I'm here to say that all of this information exists on IBLCE's website. All right, next slide, please. There's also mention of a web camera, and it says, I'm going to read because I did copy and paste this. It says you will need a movable webcam for the check-in process. A webcam in a laptop is acceptable as long as you're able to move the laptop to show the entire room. You may not have more than one webcam in use at the same time. So I'm glad there was a little pause there because there was a new note here for me to go over. All right, so before exam day, key things: plan to be alone, no pets or people, none. I get it, we're in a pandemic, but if there's a way to plan that for this amount of time that you can have no pets or people, you want to make sure you're in an area where your internet is strongest and where there's good lighting. Again, if you could plug into the Ethernet, which is hardwire, you may want to consider that hardwired Ethernet cable. But if not, just make sure you're in a spot where there's good internet. This year, you cannot use a mobile hotspot. I don't know if this was last year, but I will say that the rationale for not being able to use a mobile hotspot is because you cannot use a mobile phone. You cannot have a phone anywhere near. And so if you want to really go back and look and reread the rationale, that is there as well. So when I say make sure you're in a spot where your internet is the strongest, you really do want to make sure that that's, that you can arrange that. And ensure that you'll have quiet time. So yes, we said no pets or people. So the pets or people might be outside the door, right outside the door knocking, mommy, mommy, or daddy, daddy, or hey, open it. Yeah, yeah. You want that to be minimized. So think about all the things. We all have different structures and different things that may come up. So you want to make sure that you've considered all of those. So this is not an all-inclusive list. These are the things that pretty much is kind of juggling your mind to say, what are the things that I need to do to prepare? Next slide, please. So, exam playlist. One of the things that I would recommend before exam day, it's something to build your confidence and to put a smile on your face. Right now, the intensity probably is on 100, but include songs that make you feel good, inspired, or energized. Find a podcast that you can laugh, or maybe you're always laughing and you just need to calm and you need some meditation. Do that. Those are things that can help. Also, you might want to write yourself a "you can do it" note and place it, and this is for the future. So you can place it wherever you want to place it. But the morning of, reread it, discuss your passion, discuss barriers that it took for you to even get here. Encourage yourself because you know what it took to get here, and only you know, because we all have different challenges. All right, so those are things that can do that you can help yourself out before exam day. Next slide, please. Take your exam temperature. So think about this. What has worked for you in the past? We've all had opportunities to take some form of some type of test. Think about what strategies did you employ and how did they help you? Were they successful? And if so, use that. And I'll give an example. So for me, writing things in my own handwriting, and maybe that's a little bit too old school, but or maybe I can say, putting stuff on flashcards, whatever is your thing. But for me, it was rewriting because, and there's also some literature about this, is that when you write in your own handwriting, you can remember easier. So there is some literature about that. So what has worked for you in the past? Take that exam temperature, meaning where am I in my process? Next slide, please. The night before the exam, you've done all you can do. Relax. Just relax. Find your inner calm. Studying at the last minute Remember I said take your exam temperature. If that worked for you and that worked out fine, okay, more power to you. But for some, it causes us to second guess and to get in this heightened anxiety state where we can't sleep. You want to sleep before the exam. Sleep deprivation will have those questions popping up and all around the screen, and you'll be confused. And then, Angela mentioned that they are staying away from these negative STEM. But what about if you get that one question that has that, so you want to sleep. You want to sleep. So cramming before it is not recommended if that's not a thing that has worked for you. But even still, you want to be able to sleep so that you can get a good night's sleep. Next slide. All right, so you wake up in the morning, you got to get breakfast. This is not the day to eat something that you've never eaten before. It is not. Eat something that your body is used to. Um, Also, comfortable clothing, the temperature in your home. What things do you need? And this is exact. And even if you're going to the testing site, you do not need to dress to impress. You're taking a test, you get up, no special clothing there. Trust your preparation. Uh, and really, the goal is not perfection, it is doing your best. And wake up knowing that you are ready. You're ready. Next slide, please. So the test format is usually 175 total questions. There's two parts, multiple choice and then images. You'll get 4 hours, 30 hours, not 30 hours, you'll get 4 hours duration, but 30 extra minutes if the exam is not in your primary language. Each question has only one correct answer, and there is no penalty for a wrong answer. So remember, I said it's to your advantage to answer all of the questions and flag the ones that you're not sure about. So what's easier is to answer the question, flag them, and then go back if you have time. But you don't want to run out of time. You want to make sure you pace yourself, and you want to make sure you answer all the questions. Next slide, please. So exam strategies, and these really, really do help. Read slowly. Read slowly. I said pace yourself, but you don't want to skim. I can't stress that enough. We skip over words and you could be missing the STEM part of the question. Remember, Angela mentioned that. So you want to read slowly. And you also want to ask yourself, when you answer a question, because there could always be two best answers, you want to think, what is the first thing I would do? So that means that's the best answer. So what is the first thing? You can also do process of elimination by eliminate obvious wrong answers. And again, Angela talked about the negative STEM. Remember, this is an international exam. So for instance, when we're talking about, or if there's a question about HIV, you have to keep in mind that for those of us in the US, the recommendations might be a little bit different. Even when we're talking about things about, if there's a question about what would you do first, and it has double electric breast pump and it has hand expression. Remember, this is an international exam, so you might want to always choose hand expression over electricity, right? So you want to just make sure of those key things and keep in mind international exam. So you want to answer the question that's geared toward an international exam and not so siloed into what our own practices and cultures may be doing. Next slide, please. Exam strategy, you want to work at a comfortable but thoughtful pace. Mark any questions you like to review, make your best choice, move forward, review if time allows. It looks like I know the slide. I've already talked about this way in advance. If you go blank, breathe, guess. I said yes, guess, and move on. Next slide. And then if you get to the end of the exam and you've already gone over your flagged questions, you're done. Submit it. it's always like we get to the end and I'm usually sitting there like I just don't want to sit there. Like I'm sitting there like, don't double think it. And so I like this slide because as I was doing this slide, we all have different personalities. And so for some of us, it's just like, yep, check that, I'm done, whatever. And then there are some that look like that this little baby in the corner, my work is done, like I'm done, and some people just, it's done. And she lit the house on fire. She like, okay, I'm burning all of this testing stuff. I'm over it. So whatever your done is, it is done. Submit your exam and just breathe. And then go celebrate. Next slide, please. Waiting on your results. So everyone's going to go home, and instead of relaxing and celebrating, they're going to get right on social media. This is you're going to have all these questions and all these. Yeah, try not to obsessively check. Try not to overanalyze. Try not to think about how well someone else did in comparison to you. Remind yourself you did your best, but also you do want to stay connected to your professional community. Even while you're waiting on your results, keep learning. There's so much to learn. This is entry level, so you want to keep learning. So stay connected. Next slide, please. I know we ran over and I'm really trying to hurry up here. All right, so again, always remember your why. All of us get into this world for a reason, and those reasons are important. Those reasons, especially if you've done all your clinical hours and you've studied, just make sure, remember your why, and that keeps you grounded and that keeps you learning. And because there's so much work to be done. Next slide. So I just want to say best wishes and good luck to everyone. Thank you for joining us. There were some questions, Angela, that I figured we could answer, live.
Excellent.
Yeah.
Yes, yes. And so this is for the purpose of the recording. We did answer a lot of questions in the chat, and some of them will go out, but those of you who are only listening to the recording, you're not missing anything, right? We're going to tell you the answers to a lot of the questions that some people asked. So, chickenpox. So as far as somebody asked, in regards to active chickenpox on the day of birth, is it advised to separate parent and baby until the lesions scab over? I've seen and heard different things on this. Sekeita, do you want to address that?
So Angela, I believe you addressed it in one of your slides. The issue with chickenpox is no, the lesions, you don't want the lesions touching baby. Breast milk is still advisable. I think though that lesions may be an issue if they're not crusted over. And so I'm like you too. I want to be able to look that up, and I got my little handy dandy resource right here. So I'm going to double check
Okay,
that.
you looked at it. I'm 80% sure on this one. I know where it is. It's in breastfeeding and human lactation, which I'm going to do this here
Hmm.
because I can. It's in breastfeeding. I'm sorry, a guide for the medical profession. I know it's in Dr. Lawrence's book, and I know because chickenpox is always one of those ones that comes up.
Yeah,
And I'm 80% sure as you look it up that indeed, if there are no lesions on the chest, then
right.
it's not a problem. And so I would say that would be the answer, but I'll let you look it up. It's on page 458. Okay, I'm going to go to the next one here.
You're in Lawrence and not the core curriculum.
Correct, Lawrence.
You said
458.
458. Okay.
Uh-huh.
All right.
And so somebody had a comment. I want to confirm for exam purposes, we do not wait for 24 hours and try to clear mastitis before taking antibiotics. And then they mentioned other sources say to suggest wait for 24 hours, and some say not to. So that really has to do, and Sekeita, I know you'll check me if I'm wrong here. That really has to do with the prescribing provider. It's not up to you to make that determination as far as whether or not the parent needs antibiotics. And so indeed, while I understand the rationale behind waiting that 24 hours, it's not something which is necessary. or it's not something that may be recommended. And so I would defer to the Academy of Breastfeeding Medicine's protocol on mastitis as opposed to anything else.
I believe you're talking about the mastitis and waiting for antibiotics. No, you continue to feed mastitis, any
Well, no,
antibiotic.
but not to take the antibiotic. The question is you're not supposed to take, you should wait 24 hours before you start the antibiotic in
Oh,
case it's, okay.
never heard that. Sorry.
Well, so that's just it. So we can't really speak to other resources that say to do these things, right? Because they may have a different reason why. And so just as an FYI. Okay, another question. So you're looking up chickenpox here. Another question is, I've been asked about the contents of breast milk when tandem nursing. If milk is customized to one child, how does it adequately meet the needs of two? Is the ideal for the newborn? So indeed, I mean, there hasn't been a lot of research on this. The current theory is that indeed the milk is more customized to the younger nursling as opposed to the older nursling. But that's not something, you know, breast milk is so miraculous and remarkable and just the most amazing stuff on the planet. And so indeed, and the growth and development of the newborn is of primary concern to the lactating parent's body. So I'm going to speculate that the answer is it is the younger nursling as opposed to the older one. Okay, let's see. Move on. Is there an easy way to differentiate between tracheomalacia and laryngomalacia when listening with the stethoscope or just listening? So one thing is that it does sound slightly different, and you can hear it audibly without using a stethoscope. That said, that again is not under the scope of practice for an IBCLC to make that differential diagnosis. And so it's going to be a speech pathologist, it's going to be the pediatric provider or someone like that. And actually, I understand that on the internet, you can find, if you Google, what does it sound like, you're going to be able to find it. So there are answers. There are those answers, which is helpful. So someone else is asking about so the question with the baby, that baby was 2 months old, even though it could kind of fake you out a little bit because of the 4-month, because I put in the 4-month-old answer. And indeed, a 4-month-old is going to be able to hold themselves up and sustain it for a much longer period of time. And so you're going to see a greater arch. I will say, if you go into our handouts, in the handouts, there's some resources for developmental milestones, because developmental milestones is one of the sections on the exam that people do not score as well. And so do take a look at what is expected at different ages and stages. And the Centers for Disease Control and Prevention, the CDC in the United States, has a fantastic website on developmental milestones. So I highly recommend that you take a look at not only developmental milestones for providers, but also for parents, because it explains it in really simple language. And so get some of those things in your mind. For example, when will a baby be able to stand and walk unassisted-ish, right? When can a baby stand? Supported and unsupported. When can a baby throw a ball? Or, you know, so find out what those milestones are and remember a few of those and commit those to memory. So Sekeita, have you found the question on chickenpox?
I did. So what it says is, it says the isolation of an infant from the mother with varicella and interruption of breastfeeding should occur only while the mother remains clinically infectious, regardless of the method of feeding. As soon as the infant has received the varicella zoster IG, express breast milk can be given to an infant if no skin lesions involve the breast. Persons with varicella rash are considered non-infectious when no new vesicles have appeared for 72 hours and all lesions have crusted, usually 6 to 10 days.
Beautiful. Thank you.
You're welcome.
Nice and helpful. Also, Sekeita, you wrote an answer to a question about the pH of a drug. Do you want to read that, or do you want me to read it?
I sent it to the whole entire audience. I believe that everyone got it. So it's from Hell's book. You can read it.
Okay.
You have it popped open, so.
I do. So the pKa of a drug is the pH at which the drug is equally ionic. And so someone asked about the pH of a drug, about getting into breast milk. And so the pH at which the drug is equally ionic and non-ionic. The more ionic a drug is, the less capable of it is transferring into the milk compartment to the maternal plasma compartment. Hence, the drug becomes trapped in the milk, or ion trapping. This term is useful because drugs that have a pKa higher than 7.2 may become sequestered to a slightly higher degree than those with a low pKa. Drugs with a higher pKa generally have higher milk plasma ratios, hence choose drugs with a lower pKa. There we go. Okay, good. Someone asked a question about scores, IBLCE scores and previous test scores, and what is the passing rate for the test scores. And one thing to mention is that we actually did a webinar on this a couple of months ago, and you can find it on our website. And you can find it also on our YouTube page on how to set up a study, how to set up a study plan. And we actually go into the data there, and we actually show which areas people usually perform well and not so well. And you can find on the IBLCE website the previous test analysis score, or the test analysis results, is published by IBLCE. Now, it's not going to tell you which question people got right and which question got wrong. It's very big picture stuff. However, it does give you a little sense and hopefully some peace of mind that over 80% of people who take the exam for the first time pass the test. So there you go. Let's see, what other questions? Okay, we got this one. Let's see. Someone is asking, do we need to know normal glucose, newborn glucose levels? I would say the answer to that would be to take a look at the Academy of Breastfeeding Medicine's protocol on hypoglycemia in order and have a general level for that. So there's several questions about that. Remember that any numbers that are listed on the exam, you're not going to have to do math on the exam. And any numbers which are listed are going to be in both metric as well as in the other. That's not metric. That word is escaping me.
Is it the SI units? Is that, are you thinking of something
Yes.
different?
Yes, yes, that's it. So it's going to be listed in more than one way so that you're able to do it. Also, another quick note as I'm looking for other questions is that all of the exam questions are written with British English. Correct me if I'm wrong on that one, Julie, but I believe it's British English. So don't be surprised if the word organization has an S instead of a Z. That's the way that they do it. Let's see. Someone is asking a question that I don't understand. So if this person could re-type it in. When is DBF, direct breastfeeding, contraindicated, but EBM is acceptable? When is direct breastfeeding contraindicated, but express breast milk is acceptable? I would say, like, for example, when an abscess is healing, if the incision precludes the baby latching onto the breast, I would say that that would be one. But the breast milk is something which is fine. So it has to do with the breast milk. So there would have to be a problem with the actual parent's breast or chest in order for direct breastfeeding not to be able to occur. I hope that answers the question. Now, someone is asking a question that I know all of you are thinking, which is why I'm going to read it. Will the results be available in order to register for the fall exam if I fail? And so, yes, you will receive the exam, you will receive your test results prior to when you can register for the next exam. I do know that they provide you with a slight discount, or at least they have in the past. If you fail the exam, you do receive a slight discount and you can take the exam again. The other thing that they will do is they will, let's say, for example, something happens with the timing and the results don't come out in time. They're going to give anyone who fails, they're going to provide them with that opportunity to retest in the fall and to actually apply and to make that happen.
So there was a question about something I said about if they're taking an exam at an exam center and it says, and we have to take a break or use the restroom before the official break in between two sections, will we be disqualified? I know that there are times for a break and times that you cannot take a break. As far as the disqualification, what I referenced was uh, last year being familiar with a person who did get up during a live proctored exam and was disqualified from taking it. So I hope that clears it up. Because this is international, I really don't want to mislead anyone. What I would say to everyone is to read. For instance, I know those who do live proctoring, they get the Prometrics information. If you're going to a testing site, it's extremely important that you do the same thing, that you know the ins and outs. I can say that if you go to IBLCE's website for frequently asked questions regarding the exam, you probably could spend a good chunk of time, I would say 4 to 5 hours, reading those questions and really doing your double checks. So I would just become familiar. I don't want to say that, yeah, you will be disqualified if there's extenuating circumstances that I may not even be familiar with. I gave the example though that because the person hadn't read, and it was clear that you can, and it is still clear on IBLCE's website that you are only allowed break during authorized break times. So I really hope that clears up that question.
Great point, thank you. And again, it's a matter of following the rules and find out what these things are ahead of time. For example, for people who are taking the exam and English is not their mother tongue, indeed, there are requirements from IBLCE and there are comments from IBLCE, and so I would suggest following the IBLCE guidance. You need to have notified IBLCE if you do need additional time for the exam. Let's say if you need to pump, or something like that. So please do, reach out to IBLCE to make sure that everything is clear before you show up at the testing center or before you take the exam from home. Okay, somebody made a comment about the question on neck. And it says, the reason I didn't choose preventing neck is because you can't absolutely prevent neck solely with breast milk. It makes it seem like it's an absolute if you provide breast milk, but it's not. Can you explain why prevent is used and not a word like decrease or limit? You're smiling, Sekeita. Do you want to answer that one? No, that's me.
Now I'm smiling because yes, technicality, I would say yes, but I will also say that how do I phrase this? Coming from a hospital system, and this is just from lived experience of not having donor milk at all, the number of neck cases we had to when we received donor milk for a full year uh, dropped to only one neck case that year versus what we had the prior year. So I won't even, because you can look my bio and see what hospitals I have worked at, but I'm just going to say that it should be decrease the risk, right? Uh, but it is that important that I've seen it written as prevent. Also, I've seen it written that way, but it does significantly decrease. So we probably should, uh, you know, that's a good
Well,
catch.
it is a good catch. But then again, I mean, if IBLCE wasn't so clear on that exam question,
Yes.
still, which one is the answer? In other words, it's not a matter of telling IBLCE that they're wrong.
Yeah.
The answer is there.
Yeah.
And so it's just a matter of figuring it out. And the same is true with pictures. And I wrote a blog on this about pictures, and it's in your handouts. And, for example, the handouts, the pictures are not going to be perfect, right? They're not going to be perfectly staged pictures. And the reason why, and they're going to be mostly white skin tones. You're not going to see a lot of melanated skin. And the reason why is because those are the pictures that they have access to. And whenever a parent is, let's say in a crisis situation, baby who isn't gaining enough weight and or parent with an abscess or something like that, it's not a matter of, oh, can we turn this light on over here? Oh, no, wait a minute. Can you please do? No, we can't necessarily stage pictures, and IBLCE is no better. It's not like you can go to Shutterstock or Adobe in order to find good pictures of an abscess. You just can't. And so that's why some of those clinical pictures, they may seem a little dark. They may seem, not diverse. It's not that they are not diverse. You're going to note these things. I said it. Angela, hi. You're
Oh,
going to note
thank
these.
you. Because I was sitting here cringing. I was grinding my teeth. I was like, I wasn't going to say anything. Thank you for
Angela,
keeping it real, though.
yeah, I am. But you know, there's only so much that can be done, and so indeed, try to take those criticisms and set them aside and focus on the job at hand, which is to get the question correct as far as what they're looking for.
Right. So I would say to that, Angela, that would be one of the, because that's how my mind thinks too. So whoever asks that question, I'm technical and literal like that. I would sat there on that question and been like, well, prevent, right? Uh, I think, there's always two best answers. You choose the best one.
Absolutely.
And hey, remember I said the goal is not perfection, it's to do your best, you know? So,
And to those of you who this is not your first time at the rodeo, I was chatting with someone the other day, and it's her fourth time taking this exam. And by the way, she's not studying. And she told me, she asked, she said, "Is there a way for us to give feedback? Because in the past, you used to be able to give feedback, and no, there's no longer an avenue for you to provide feedback. And I would also caution you on confidentiality. In other words, this is not the time to get together with your colleagues and go over every single question and hash out the details, because you are bound by the IBLCE confidentiality rules that you will not disclose the information which is actually on the exam."
yeah.
So,
The other thing I want to say, because I think we said this and we addressed this the last time, but it just came up to me based on that question. Um, I referenced that there are people that are taking the exam from, some people don't realize that you don't have to be in the medical field to take the IBLCE exam. So with that being said, you have to realize that this is for entry level. So those of us that have a little bit more prior clinical knowledge, we might sit on a question and be thinking, but what if this and what if that? You don't want to do that. You want to just answer the question. And so I also want to preface it that way, because sometimes knowing a little bit too much can also be detrimental, right? And so we want to make sure we keep that lens when
that's
testing.
very good point. We're just going to answer another couple of questions, and then we're going to let you go because we've gone way over time. Thank you all for sticking with us on this. The person clarified the question: when should you not breastfeed the infant, but you can provide mom's express breast milk, viruses, etc., not breast pathology? And so in that situation, I would take a look at the true contraindications of breastfeeding, which is provided by WHO or CDC, as far as which. So the CMV one is a good one. And also, somebody mentioned TB. And so tuberculosis, if the parent has active and untreated tuberculosis, then indeed the breast milk could not be provided to the baby. And someone made a comment about the question that we had about powdered infant formula, the storage question, if it's 24 or 48 hours. And it's funny because when I saw the 48 hours there, I was like, is that right? And so y'all caught it. Thank you very much. Appreciate that. And so indeed, we did look up the answer, and the answer is 24 hours. So it is. Did you notice that too, Sekeita?
No, I didn't.
Okay. So it is 24 hours. So you can refrigerate formula, powdered infant formula. You can reconstitute it, create it with the boiling water, with the boiled water at that temperature, and then store it in the refrigerator for 24 hours. So thank you very much for mentioning it. Other questions here about getting if you have to wait the full 2 hours until you can take part 2, or if it's something where you can just go ahead and go straight into part 2. I tagged Julie on this question because I don't know the answer. Sekeita, do you know the answer to that one?
I
I
can
think
say the last time I said I went into a testing session and I was able to continue going. And I don't know if that was specific to that testing.
so.
Again, yeah.
Julie just popped it in the chat and she said you can go right in. So you can go
Yeah.
right into the next session. And so someone else is asking if they should bring a lunch and a bottle of water. I don't think you're not going to be able to bring any of that into the testing site. And so, while they give you that much time, 98% of people that I've spoken to, maybe 95, okay, have said that they had more than enough time to go back, answer the questions, and take a look at the ones that they had flagged. So just as an FYI. So I would not I mean, you have to, if you're going to a center, you have to leave your phone outside. You know, everything is gone. So it's not something that you can necessarily bring. Okay, good.
I think that was
I
it.
think we're good. Great. Okay. Well, thank you all very much for joining us today. Again, do download the handout. For those of you who are watching the recording, the handout should be available with this recording. And so do take a look at it. If you have any questions, do feel free to reach out. The fastest way to get someone to answer your question is to email the support@lactationtraining.com. And the reason why is because we have people who are checking it 7 days a week. And so we will go in and take a peek and see if there's anything there, which is something which is urgent. We have several IBCLCs on staff, certified breastfeeding specialists on staff, La Leche League leaders on staff. They work for us. And so they can answer a lot of those questions, or they know how to, you know, get it to the right person who can answer the question. So please do reach out to support@lactationtraining.com. I'm going to say something, even our tech person, our tech magician, his wife is an IBCLC. So we can get answers to a lot of these questions relatively quickly. So please do. Anything else, Sekeita, you'd like to add?
I just want to thank everyone for joining, and I want to just extend, true, sincere best wishes for your exam and your preparation. And I just want to extend the same thing to Angela. Don't struggle with something. If you're having trouble understanding the rationale, please email it, and we'll help you as much as we can. Yeah.
That's it. Great. Well, thanks, everyone. Really appreciate your time. This was very fun. Thank you so
All
much.
right. Thank you. Bye-bye.
Bye.